Thank you, dear friends. It's an honor to be one of the speakers here in this distinguished symposium, and I have very much enjoyed the previous speakers, and it's partly, or to a great extent, because of the work they have done that it has been possible to make this quantum leap also in this very youngest patient population. So what I have been asked to speak about is what has happened with the treatment of the small children who have congenital nephrotic syndrome, who have a nephrotic syndrome from birth. In the 1950s, that we have been hearing about today, some of these patients were seen and their prognosis was very bad. Most of them, or almost all of them, died within usually a couple of years, most of them within the first months of life. And today the picture has changed. We know much more of the causes of the disease. We have learned a lot about molecular genetics. And as you have heard, dialysis and transplantation has developed immensely. And today these babies can live a practically normal life. This guy has congenital nephrotic syndrome, here as a teenager winning medals in athletics. So how did it all happen? Well, already during the 1940s and 1950s, there were occasional descriptions of patients who had a nephrotic syndrome. But I think that one of the first publications where really the disease was described, and to a great extent the clinical picture was described as it is today. I don't think much can be added from that. And that was Niilo Hallman, my first boss. He was one of the founding members of the ESPN, and the third meeting was in Helsinki at that time. And together with Hjelt and Ahvenainen in 1956, they described 8 patients with a similar disease. They had a big placenta, they had edema from birth, they had severe hypoproteinemia, a lot of proteins in their urine, and they had a high cholesterol. And they all died. Subsequently, there were more cases also described, single cases from here, from different parts of the world. So it was a rare disease, and there was no treatment to that disease at that time. Now, the researchers were wondering what it could depend on. One theory was infections, and as we know, congenital nephrotic syndrome can be caused by infections even today. One was speculating about nephrotoxic drugs, that the mother had taken, or some nephrotoxins that had an influence on the fetus. And then very much research was done about immunological reasons, that there would be an immunological mechanism that would make it a disease on the kidney of the child. So that was a lot of speculation about that. Then slowly there were single reports about several siblings in the same families. And in 1957, patients where the parents were intermarried were described. So one started to think about if it could be a hereditary disease. So there was more and more speculation about that. I think the immunological theory was the one that was most dominant at those times. And the older ones can correct me if I'm not right, but that is from reading the literature from Niilo Hallman that I get the impression. Now in 1966, Reijo Norjo, in his thesis, he collected 57 cases. 2/3 were from Finland, and 1/3 was from the literature, who had evidently the same disease, congenital nephrotic syndrome. And in Finland, we have very good, the church has been keeping track for many hundred years about where people were born and how they were married and so on. So he was able to track back the families of the patients to about 1690, 1700. And he could show at that time that the so-called Finnish type, because it was Neil Howland and his group that described it, was an autosomal recessively inherited disease. So that was one step. Now, as we have heard, during these times also dialysis was developed. Also in younger children, it was done in different parts of the world, in the United States to a great extent, and also in Europe slowly. And also the group of Neil Hallman, they constructed a hemodialyzer, and they dialyzed a few patients. And you can see here in the bottom, at the bottom, they had actually dialyzed 3 patients with congenital nephrotic syndrome of the Finnish type at that time, and one of the kids had 50 dialysis. They did well, and they did try to transplant 2 of these children. But there was no knowledge about immunosuppression and so on, so it didn't go well. So that was an unsuccessful try in Finland, and for many years we didn't try to do renal transplantation in these youngsters again. But as we heard before, in the United States especially, Starzl and also the group in Minnesota, they started with renal transplantations in children, and then slowly it also came to Europe. Now in Minnesota is a special place because there are many Scandinavians, and there are also many Finnish people with Finnish ancestry. So in 1973, they reported a successful renal transplantation in a child with congenital nephrotic syndrome, and in 1984 they reported 41 such patients. The 24 last of these had been actively treated with the dietetic manipulations, optimal nutrition, and so on, with dialysis, and subsequently also with transplantation. In these patients, they had tried steroids and cytotoxics without any effect, as we know also from other centers when these drugs have been tried in that, but it didn't work. 8 of them were bilaterally nephrectomized, half of them had a family history, and 1/4 of them had Finnish ancestors. And the 2-year patient survival and the graft survival was 80% and 71%, so pretty good. Their height was not very good, and they had a lot of complications, thrombotic complications. They had a lot of infections prior to this, especially prior to the transplantation. But anyway, there was a successful treatment for this disease. Now in Helsinki, after the first unsuccessful transplantation in the early years, these children were not really, it was thought that it was unethical to try to treat them, so they were not treated. But in the 1980s, in the beginning of 1980, we started an active transplant program for children of all ages. So the first renal transplantation during this time, teenagers had been transplanted in the adult units before, but the very young ones had not been treated really. So then now about 300 renal transplantation have been done. The same group takes care of all the transplantations, so it's 140 livers, combined hearts, and so on. And you can see that when we look at the etiology of chronic renal failure or severe renal diseases, it's very different in Finland than in other countries. 40% of the kids who don't survive without a new kidney have the Finnish type of congenital nephrotic syndrome. And today we have treated 107 patients after the beginning of the 1980s. And of course, this has been possible only through the development of dialysis, the new methods, the machines, better understanding of nutrition, use of growth hormone, and taking care of the calcium phosphate metabolism, and also about the development of renal transplantation in younger and younger children. And you can see that if we look at the results of renal transplantation today, here we have the Scandinavian registry that reported a year ago the results, and you see in the very youngest one, the ones that are less than 2 years old, where the congenital nephrotics are the 3-year graft survival, both for living related donor and deceased ones, is 95%. So it is as good as for the older age group. Now we also have the EDTA registry, and Tuula Höltä has checked that registry and compared how the Finns do when they treat these and how the rest of the European countries do, and compared that with children of a similar age who have another renal disease. And you can see that the graft survival in all these cases are similar, which means that today we can successfully treat these patients with dialysis and with renal transplantation. Now, what's the treatment? As you know, we have to take care of nutrition. We have to substitute them with albumin so that they are not edematous, that they have a high enough albumin. Take care of anticoagulation. That was a big problem in the beginning when they not were anticoagulated. Substitute with thyroxine, treat aggressively infections, and add vitamins and so on. And with the modern dialysis and the machines, you can do both hemo and peritoneal dialysis successfully in these youngsters. Now there always comes up the problem about nephrectomy or bilateral nephrectomy or not. And I don't really think that is a problem. There is no contradiction in this situation. It's an individual decision that you have to make. Because in 1989, Coulthard in the UK reported a patient with congenital nephrotic syndrome. We don't know exactly what the mutation was in that patient, and they took out one kidney. And you can see that the albumin concentration comes down slower in that patient if you have only one kidney, which means that after having everyday infusions, they could have every other day, then later every 4th day, and so on, because the child went to uremia and subsequently got a renal transplantation. Now the problem with the Finnish patients that we are faced with is that the proteinuria is extremely severe. So if you take one kidney out, it doesn't change the treatment really. You have to go on with the albumin infusions, and you still, it's hard to control. And so I think the philosophy here is that if you have severe proteinuria that doesn't react to any medication, if you have reduced growth and quality of life for the family and so on, or if you see a lot of complications, it's better, and if you are in a center that is used to dialyzing small children and transplanting them, it's better for the child and the family to take out both kidneys, have a short period of dialysis, and then do renal transplantation, and they can go home. Also in the beginning, the complications that we saw, as they did in Minnesota, were mainly seen before renal transplantation, during the proteinuric stage and during dialysis. So I think this is an individual. I mean, if the child does all right, if the proteinuria is not so severe, you can go the other way. I don't think it's one way or the other. You have to make an individual decision there. Now, what more happened with the congenital nephrotic syndrome? At the same time, because we had a lot of genetic people in Finland, and we were, of course, trying to find genes, as also others did. Marjo Kestilä was doing her thesis in Kalle Tryggvason's laboratory in Oulu, and with her we first excluded a lot of candidate genes. And at that time, everybody suspected that the defect in the Finnish type of congenital nephrotic syndrome would be in the basement membrane, that you would have less of the positive charges there and so on. But in her thesis, she excluded all this, as we also did looking at the basement membrane. And then finally, in 1998, Marjo isolated the gene, which is an adhesion, and itself is in chromosome 19, and its cell product is an adhesion protein, and we had two different names for it in the beginning. But in the beginning, with Kalle Tryggvason, we decided that we should call it nephrin, and I think it fits pretty well. It is kind of a nice name. Then, together with Vesa Ruotsalainen and Ulla Lenkkeri and Päivi Ljungberg in our laboratory, we could isolate the nephrin to the slit membrane here. So, and you couldn't find it anywhere else but in the slit membrane. So the theory was that it was the main component of the slit membrane, building connections there and keeping kind of the podocytes together. So this started the podocyte story. And after that, there has been a lot of investigations and research, and today we know a lot more about this cell. Now, our bad luck was that the 90% of the Finnish patients have a mutation called Fin major or Fin minor. And as you can see here, in this mutation, you don't have any slit membrane at all, which means that these children who have these two mutations, they have an extensive proteinuria. We know today that there are other mutations and there are other genes that may cause congenital nephrotic syndrome, and they may be less severe. They may be as severe as these ones, but they may also be less severe. So you see that NPHS1 was the first of these podocyte genes that was isolated by Marjo, and then after that the French group, within a year I think, isolated another gene, important gene, the podocyte gene, and NPHS2, and we know that these are one of the two most important there for the filtration. And here you can see also that we see them, especially the nephrin mutations in the very young children during the first months of life. But the other mutations can cause proteinuria also later in life. And now we know a lot, here are not all, of other podocyte gene mutations that can cause proteinuria. So our whole picture of filtration and of the mechanisms of proteinuria have actually changed by studying this one gene. We also have syndromatic forms we know today. So we know today that the podocyte is an interesting cell that somehow keeps the glomerulus together and reacts to different changes in the blood pressure and things like that. And different genes that are either in the slit membrane, within the cell, in the actin skeleton, in the mitochondria, or somewhere else, they may influence filtration and they may cause proteinuria later or earlier in life that may be less severe. So it's, in a matter of fact, a little bit different diseases we are talking about. Now, we heard, usually you cannot treat these. There's no medication for that. But there are some exceptions. We had a patient that had the Fin major mutation in only one gene, and chromosome, and in the other one not. And when we gave indomethacin and ACA inhibitors, that patient went into remission and has remained. The child is now a teenager and does perfectly well. We also know that when, for example, Anna Lahdenkari looked at 25 adults with minimal change in nephrotic syndrome, that there was one patient that had a Finn major mutation and another nephrin gene mutation who had just had kind of nephrotic syndrome but went into a remission and so on. And if we look at reports about CNS patients who have been treated with different medications, there are single patients that have reacted to ACA inhibitors. Many patients do if they don't have a severe defect there, or even some to steroids. So it's individual, it depends on the defect or the disease that you have. Now we heard earlier that steroid-resistant nephrotic syndrome doesn't recur, but now to our bad luck, in Finland it does, because if you have, this was first reported by Kuusniemi in 2007, who showed that if you have a Finn major homozygote, you have never seen nephrin in your life, and then some patients can develop antibodies, and that can cause nephrosis in that patient. So about 1/3 of the patients who have this mutation, now luckily you don't see many of these because you have other mutations. So that's a Finnish problem. And when we looked at the last patients that we have treated, most of them we have been able to get into remission with cyclophosphamide first, then plasmapheresis, and with rituximab. But it's a little bit hard to say which medication works, because they all have had many of them in different situations. But anyway, we have been able to manage them. In the beginning, we lost them. So we have gone a long way from the 1950s, when the future looked like this. Today we know a lot about filtration in the kidney. We know how to treat patients. This guy is now an engineer, he's married and has a son and is doing well, but as you know, many of these need another kidney later in life, and there are still other problems also. And this is, of course, the work of many people. So the multi-professional team that Alan is going to talk about is extremely important here. Now I want to close with one picture, and I'll ask you why I show this. It's not because of the gentleman on the left, myself or Juha Kere, who's on the Nobel Committee, genetic person. It's the lady. Who is she? You know, so don't tell me. Do you know who she is? She's Marjo Kessilä. She is the one who isolated the NPHS1 gene and characterized the gene product, and who together with her boss and myself made the name nephrin. I want to show it because I don't think that the nephrological community knows her, and I think she earns all the credit that she can get. She's a very nice lady. Thank you.